tonight we're going to be talking about COPD, which is an important topic, obviously, from a respiratory medicine point of view, because it's very common and patients can be affected quite badly. And I'm very pleased tonight, as Leah said, to be joined by Tim Cheung. Tim and I have worked together for quite some time now, and so it's excellent to have his support here tonight as well and to be talking to you. And that'll also give us a really great opportunity to answer questions and get a different perspective on things. Right, tonight we're talking about COPD, and what we really want to try and do is talk about a few things that we do in our practice with regards to the management of COPD, to hopefully make it a little bit simpler and easier for you guys in general practice. So we'll talk a bit about the diagnosis and the importance of lung function testing, treatments that I think that apply to everyone, and then individualized symptomatic treatment that apply to people depending on their situation. Then Tim will talk more about how to assess control in COPD and how to assess sort of refractory COPD and when you get inadequate response or when things get a little bit tricky. So I think it's useful to start with a case study, a bit of a story. And this is actually a guy I saw just the other week. And he was 77 years old. He'd smoked in the past, but had stopped smoking. And he presented with 2 weeks of worsening shortness of breath with some atypical chest pain. It was left-sided, not necessarily pleuritic, but it didn't sound cardiac either. His chest was certainly clear on examination. And this was his chest x-ray. And maybe if we just bring out the chat, and if anybody wants to make a comment with regards to the chest x-ray, they can certainly feel free. I can tell you what the radiologist said. The radiologist said, which I'm sure you've seen in the past, the lungs are hyperinflated, consistent with COPD. And it's often not a helpful report because firstly, it's labeling the patient as having a disease, which is, as we'll find out, a clinical diagnosis based on spirometry, not based on radiology. But sure, you could say that it's hyperexpanded because if we count the ribs, you can see more than 6 anterior ribs. But that doesn't necessarily mean that they've got COPD. They also had a CT scan. Does anybody want to have a look at the CT and comment on what they think is the abnormality in the CT, which is relatively subtle if you don't look at CT scans all that often. But the CT shows that there's a bit of emphysema. And emphysema is essentially loss of lung tissue. So you can see little black holes in the lung surrounding the blood vessels there. And so there's clearly some emphysema. So the question is, what is the diagnosis? And if we know what the diagnosis is, do we know how to treat it, or do we need to do further tests? I think the answer is that we need to do further tests, because we can't make a diagnosis for this patient based on their history and their X-ray or CT. We could say that they've got emphysema because we can see that on the scan. So we could make a diagnosis of emphysema. We can't make a diagnosis of anything else. And so this was his lung function. And so this surprised me. And at first glance, you can tell it's normal because it's all in the green. And so if we look at it, the first thing that we look at is the ratio of the FEV1 to forced vital capacity, and it's 0.94. So that's normal. So that tells us that there's no airflow obstruction. So just looking at that one number, we can say this person, despite the emphysema, does not have COPD. Their FEV1 is excellent. There was no bronchodilator response, and their gas transfer was normal as well, which is interesting because usually in the setting of emphysema, we see a reduced gas transfer. However, what that suggests is that the emphysema that we can see is not significant enough to have affected the gas transfer. So I often like to explain this to patients as it doesn't really matter what your lungs look like, it matters how they function. So it doesn't matter what a person looks like, it matters what they're like on the inside. And so it goes the same for your lungs. Sometimes we can see abnormality on the scan in the setting of emphysema, but if the lung function is normal, that's what's more important. So we should really be concentrating mostly on function, the patient's physical function, but also their lung function as measured. What about if this was their lung function? So if this was the same person and they presented with this lung function, does anybody want to have a bit of a go in the chat? Just put in there quickly. We can see that there's red, so it's not normal. What does this show? And so there's the number that we need to be looking at. So the ratio is low, exactly. The ratio is reduced. So that one number is less than 0.7. The ratio of FEV1 to FVC is reduced. So that means there is airflow obstruction. And yes, that means in the correct clinical setting, the patient's got the symptoms, got the exposure, and has got the airflow obstruction. That means that this person does have COPD. And their FEV1 63%, which is reduced. They've also got a reduced gas transfer. Sorry, no, there's no bronchodilator response as we would expect in COPD, and their gas transfer is reduced, and that would be more consistent with at least a component of emphysema, because the gas transfer tells us about the ability for the lung to get oxygen from the air into the blood, so it tells us about the pulmonary parenchyma. So here's another lung function test. And so say if this same person had this lung function test, what's going on with this one? We need to get a little bit closer because it's a bit smaller. The test has been done in a different lab, which makes it a little bit hard because it's not color-coded, and we need to orientate ourselves to where all the numbers are. But the most important number there is still the FEV1 to FVC. And so what does this person have? In the chat, I can see the numbers there. Does someone want to have a go at what this person has? There's the main clue. So this person's got airflow obstruction because their ratio is less than 70% or less than 0.7. Their FEV1's a bit reduced, but this time there's a significant bronchodilator response. So they've got an improvement after the bronchodilator of 19%, and it's gone up from 2.8 litres to 3.3 litres. So a 500 ml improvement in FEV1 is a large bronchodilator response. So what's this person got? This person's most likely got at least a component of asthma, exactly, asthma, excellent. So how do we diagnose COPD? And so we diagnose it with three main criteria. We need to have a patient with the correct symptoms, the presentation, and the presentation is usually of cough, shortness of breath, wheeze, sputum production, or some combination of those symptoms. There needs to be some sort of exposure to put them at risk, which obviously most commonly is cigarette smoke, but it could be biomass fuels for people who grew up in some countries that use a lot of biomass fuels, some fumes and dust and occupational exposures. And then to make the diagnosis, as I said, we need to see airflow obstruction. And so that's why doing lung function tests is the most important test in these patients, or anyone really who presents with respiratory symptoms or with a known diagnosis of respiratory disease. And so then, as I showed in those lung function tests, we do need to differentiate the COPD from the asthma. And sometimes, as in those two cases, or the case I showed with the lung function showing COPD and one showing clearly asthma, sometimes on spirometry, it can be quite straightforward. But it's not always as straightforward as that. And so sometimes we get a bit of a clue as to the age of onset. So some patients may have had symptoms when they were younger, childhood asthma, grown out of it, and then redevelop symptoms. Obviously, a smoking history is important. If someone's never smoked, unless they've had some other significant exposure, you have to think maybe this is more likely to be asthma than COPD. Sometimes patients have a family history or have atopy or eczema that can go obviously frequently with asthma. Sometimes the pattern of symptoms, people with COPD tend to be symptomatic more often, where people with asthma might have sort of episodic symptoms. The spirometry I've spoken about, and sometimes blood tests can help a little bit. If there's an elevated eosinophil count or an elevated serum IgE, may suggest that they're atopic or have an allergic type phenotype. And then response to treatment. So if someone responds well to inhaled steroids or prednisolone, then they may be more likely to have asthma. Having said that, patients with COPD sometimes also respond to those therapies. And so what are we going to do for these patients? And so the first thing that we're going to do if they're still smoking is spend a lot of time to try and educate them and trying to help them to stop. And that's certainly going to be the single most important intervention. It's the one that's going to be the most important from a survival point of view. It's the one that's going to be most important from a symptom point of view, from a loss of lung function point of view, and the one that's going to have the greatest effect on their overall health as well as their lung health. This is one of my favorite images. Kellogg's, certainly not a brand that has any interest in our health and used to make asthma cigarettes. And sometimes you'll have patients tell you that they remember these asthma cigarettes, that it was recommended to try and help with the cough and help with the sputum production. That's gone out of favour. And this is a real worry when people you'll hear about people with their Ventolin puffer and their cigarette, and they'll have a Ventolin before or after, which is no good. The next challenge we're facing, obviously, is now with the tobacco being probably on the reduction in terms of how many people are taking up smoking cigarettes. The e-cigarettes are certainly taking over, and it's quite concerning that a lot of the e-cigarette companies are owned by the big tobacco companies, and the concern is that not only the e-cigarettes might be bad for our health and bad for our lungs, which they almost certainly are, they could lead to people into smoking, and this is clearly a major problem in kids at school at the moment. They make a massive plume of smoke if you've seen anyone using this, and they're very aggressive marketers and even use us to market. But they have all sorts of flavours and they're very attractive to kids, which is a huge worry. Once the patient has quit smoking, or we've spoken about that, or maybe they're an ex-smoker, which means we don't need to worry about the smoking cessation part of it, pulmonary rehab is really important. And pulmonary rehab is a really beneficial thing to anybody with any degree of COPD who is symptomatic. It has a lot of benefits. It's not just the exercise, but exercise obviously plays a large role. There's also an education component, helping them with their inhalers, assisting them with smoking cessation, and providing psychological support. And patients really like it because they put into a group with a whole lot of like-minded people with similar sort of struggles, and they gain a lot from that. It's evidence-based. It increases exercise capacity, improves quality of life, improves shortness of breath, and reduces exacerbations. And so pulmonary rehab is way more effective than, apart from smoking cessation, is way more effective really than anything else that we have to manage COPD. Sometimes I think one of the reasons that patients don't end up going to pulmonary rehab is that it can be difficult to enroll someone into it. And so this is a screenshot of our practice intranet called iLung iSleep, where we have instructions, clear instructions, and I can send this to you, but there are good pulmonary rehab programs around. There are private ones through Epworth, the rehab centre in Glen Waverley, and also through Cabrini. And there's also pulmonary rehab available in Traralgon and also South Gippsland through the Gippy Gaspers in Warragul and also in South Gippsland. And there's also a site called iLocate Health. I'm not sure if people have seen this, but this is really terrific. If you just go to ilocatehealth.com, and then up in the corner here, you can put pulmonary rehab program and put in your suburbs. So I was put in Bentley, and just tells you where they are. And then if you hover your mouse over it, it'll tell you the contact details and how to refer to them. So wherever you are practicing, if you want to refer someone to pulmonary rehab, there's a great resource there that can be used to find somewhere to send them to. This is a favourite topic of mine. I think that it's important for everybody, especially patients with COPD, because often patients with COPD are overweight, and often their weight is contributing to their breathlessness and their symptoms. And so this is what I believe, and I know that I'm talking to some people here that are preaching to the converted, but we should be eating a diet that's low in carbohydrate with lots of animal product and natural foods, with natural fats, and avoiding this terrible starchy processed food that we've come to accustomed to and told that we should be eating. So we should be on a low carbohydrate diet that's high in healthy fat that will help achieve weight losses, which is beneficial for everyone, especially those with COPD, improves blood pressure, reduce risk of diabetes, and reduce risk of cardiovascular disease. All patients should be vaccinated with influenza, pneumococcal, and now COVID. And so once we've done that, we've got achieved smoking cessation, they've been to pulmonary rehab, they're on their low carb nutritional diet, they're feeling fantastic. If they're still symptomatic, what we then need to do is just individualize the treatment to the patient. And so some patients have a lot of cough and sputum production as their main problem. And so they benefit from chest physiotherapy, antibiotics if there's infection, and sometimes mucolytics. If their main problem is breathlessness and shortness of breath or wheeze, they benefit from bronchodilation. Sometimes if they have frequent exacerbations, they're the patients, or if they have a component of asthma, they're the ones that tend to benefit from inhaled steroids. And occasionally when they have chronic hypoxia, they benefit from long-term oxygen therapy. It's really only on those patients who are hypoxic all the time at rest that they get the main benefit from oxygen. Most patients with COPD don't benefit from oxygen and don't actually need additional oxygen. So with regards to the inhalers, this is when I first started respiratory medicine, things were very easy, probably one of the reasons why I did it in the first place. Obstructive lung disease, as it still is broken up into asthma and COPD. And you give people Ventolin, and if Ventolin wasn't enough, you just put them on Seretide, and that was pretty much it. Towards the end of my training, we got Spiriva, so that was very exciting. We had another puffer to help patients with COPD. However, over the preceding few years, things became a lot more complicated. And the good thing from a respiratory medicine point of view is it meant that we had more tricks up our sleeve to be able to treat patients, but it caused a lot of complexity. And more recently, it's become even more complicated still. And so I've spent quite a lot of time putting together this sort of chart that I try and I find useful to sort of try and conceptualize where all of these inhalers fit in. And as I've said, the most important thing is to work out if the patient has asthma or COPD or some combination of both. And from that, we can determine what sort of inhaler they need. And so the COPD patients, most importantly, need bronchodilation, and the asthma patients need mostly inhaled steroids, with the addition sometimes of the bronchodilators as a second line. Now, despite the fact that there's 18 inhalers there, and that the pharmaceutical companies will all tell you why their one is the best, I like to think that this is quite simple, because at the end of the day, all we have is two mechanisms of action, or two things that we can do with these inhalers. We can either bronchodilate, or we can treat inflammation with inhaled corticosteroids. And so they're the only two things that we can do. And within that, there are two ways we can bronchodilate. We can either use a long-acting beta agonist, which acts on the beta receptors of the smooth muscle, airway smooth muscle, to cause relaxation. Or we can use a long-acting muscarinic antagonist, which also acts on bronchial smooth muscle on the muscarinic pathway to cause relaxation and bronchodilation. So they both cause bronchodilation. Together, they create more bronchodilation than one alone. And so now that we know that all we can do is bronchodilate or treat inflammation, we just need to work out in what way we want to do that. And some inhalers are twice a day, some are once a day. Some patients prefer one device or another device, or you can just choose which ones that you prefer, that you have success with, and just use those ones to treat the patient. Because if you've worked out what the patient has in terms of the underlying diagnosis, then you know what medications you want, and then you can have a look through the chart and determine which ones suit best. And the red arrows are the ones that are licensed for use in asthma, and the blue arrows are the ones that are licensed for use in COPD. If anybody, you can take, hopefully if you've taken a screenshot of that, I find that really useful. I still refer to it in clinics. If not, otherwise just put the word yes into the chat box and I'll send these to you. Because the other thing I've done is gone through and put all of the medication names, because we should be using generic names for medications, but it does become confusing. So it is useful to know, because patients will probably know the generic name for their medication, but it's important that we know what medications within those are, and then the class of medication, and then the dosing, and that's all 18 of them. So hopefully that's useful. I will certainly send those out and for you to use as reference. And on that note, I will end my show and I'll hand over to Tim.
My portion of the talk will be on assessment of COPD and troubleshooting difficult to treat COPD. We need to spend a little bit of time talking about pathophysiology and some phenotypes. I'll go through a case study, then talk mainly about assessing the severity versus impact of COPD. There's a slight difference between the two I'll go into. Then the investigations for refractory COPD, and when things don't work out, if there's progression of COPD, what then? But first, I wanted to dispel a few misconceptions about COPD. The first one being that COPD is only caused by exposure to cigarette smoke. We now know that in actual fact, 30% of patients, if we take it into global context, are non-smokers. And that's due to exposure to other risk factors, such as biofuels from indoor wood fire heating or cooking, environmental pollutants. We know miners have higher risk of COPD, as well as living in areas of heavy air pollution. The second one is that pathology of COPD is only affecting the lungs. And while that's true, sort of predominantly, COPD definitely is a lung disease, but we also know that it's a systemic syndrome, systemic inflammatory syndrome, in fact, that affects things such as skeletal muscle, nutrition, And there are other comorbid conditions that are more frequent in COPD, such as ischemic heart disease. Now, the third one is sort of more true of perhaps a layperson often equate COPD as emphysema, and I've been guilty of explaining using those two terms synonymously just to make it simple for the patient. But sometimes that might be doing them a disservice because it fails to recognize the other components of the COPD, such as chronic bronchitis, where there's mucus production and the whole systemic part of it. So a way I introduce it to patients with the diagnosis is that you have a diagnosis of COPD, and that's caused by whatever risk factors, such as smoking. But that also forms part of a larger condition called COPD, and then I go on to the specifics there. I won't dwell too much on the pathophysiology, but the main points of this is that it is a continual sort of process of injury due to risk factor exposure, and there's continued injury, repair, remodeling, and a sort of vicious sort of cycle that causes chronic inflammation, initially affecting the small airways in what's termed the quiet zone of the respiratory system, the terminal bronchioles, and that can go on for quite some time undetected. But as ongoing risk factor exposure and inflammation progresses, that affects the more proximal airways. That's when you start to get airflow obstruction that becomes fixed. That's when you come short of breath, and it affects the more distal airways, and it causes emphysema, the lung destruction of the lung parenchyma. And in more late phases, the hypoxic vasoconstriction can lead to complications such as pulmonary hypertension, and that leads to hypoxia. What's more important than, or equally important than risk factor exposure is also lung health in general. We know that early exposures to risk factors can significantly affect your trajectory of lung function decline in later life, and also beneficial things such as good lung health through exercise, good diet can give you protection from lung damage. If you're exposed to risk factors, there is an accelerated lung function decline, but you can be somewhat protected and have your baseline lung function boosted up through maintaining good lung health. But when you do develop this condition of COPD, it's important to try and characterize or categorize the form of disease that the patient has. It's been classically described in textbooks as two forms: the pink puffer, thought to be more emphysema predominant, and versus the blue boaters, which is more of a bronchitis, mucus-producing sort of forms. But I guess a modern take on that is that we look at more of the pathophysiology and the clinical aspects, whether they're having lots of exacerbations, lots of flare-ups, versus quite stable, but a lot of symptoms at their baseline. That's probably a little bit more useful than just looking at how they look in front of you. So talking about a case study, I recently saw a 60-year-old man who was an electrician. He was an ex-smoker with a 20-pack year history after stopping smoking 10 years ago. He has an established diagnosis of COPD, which you made because you listened to Barton's talk and you did the spirometry, so you know that he's got mild obstruction without bronchodilator response. They've ruled out asthma. And initially, he just had a bit of shortness of breath walking up hills, a bit of hyperinflation on the X-ray, so it was appropriate to start him on a LAMA inhaler such as Spiriva. He had a few comorbidities, but nothing significant in terms of cardiovascular disease. He was the type that's a bit stoic and doesn't often come to see you, but on this visit, it's been about 2 years and he's reporting a bit more breathlessness. It's been worsening gradually. It's worse in the winters, but he tries to tough it out at home. But he is struggling to keep pace with his friends, and he's starting to cough all the time as well, to the point where he's couldn't really do on the job site on site to work anymore, and it's taken up a desk job. On examination, he was normal oxygenation, on room air, no clubbing, just a bit barrel chested, reduced air entry, but without any crackles or wheezing. And the remainder of the exam was fine. So you repeated the lung function testing, and I guess I'll throw it open to the chat to see if there's any comments on this one. Again, that's sort of the ratio at baseline, and this is post-bronchodilator. This is the FEV1. This is the lung diffusion capacity. So we can see that the ratio is reduced. Exactly. So that shows a mild degree of obstruction, and lung diffusion capacity reduced as well. So again, it's a picture of COPD consistent with your initial diagnosis. So what other questions would you ask, given that he's presented now, says he feels a bit more breathless? I guess I'd be interested in sort of characterizing that cough he described. Is it there all the time? What sort of volume of mucus, if any, he's producing? Has there been any infective production of any or any infective precipitants? Has he needed to use his rescue inhaler, his reliever inhaler much, and how often? Those sort of things to determine the stability of his disease. So, would you say that Mr. RZ's COPD is well controlled? I wouldn't think so, given that he's got progressive symptoms, and it sounds like a few exacerbations in there as well. What investigations, if any, are indicated? I guess things that might help you with trying to work out why things have progressed. We might go into that one a little bit later, but just have a think about these questions. Is he smoking? Again, yeah, it's a very good point. Yes, it's always important every visit. Don't assume that if they've said that they've quit for good. There's always risk of relapse. So very good point there. What is your management plan? Well, we'll discuss that also in a bit later. So that's the chest X-ray, and there is a bit of hyperinflation. The thing that gives it away is more than 6 anterior ribs, and the flattening of the diaphragms you can see from the loss of that cosophrenic angle. So how do we assess COPD control? I suppose there's several frameworks to use, but this is the one I like, and I'd like to share this with you as well. So the 3 points are assessing severity, impact, and stability. Severity and impact sound very similar, but I suppose the difference is that severity is more of an objective measure, an overall view of the patient's symptoms at a point in time, and especially helps with prognosis and their initial management. Things like their degree of airflow obstruction, their weight and BMI, exercise capacity, 6-minute walk distance. The impact is more of a subjective thing. So how is the symptoms affecting the patient right now? What it's things like the degree of breathlessness, the sputum burden, is it affecting their sleep? Things like that. Stability is exactly as the term implies. Is there any change in their status over time? So the 3 things to assess. Severity, yes, it's sort of their overall. If we're talking about symptoms, not so much interested in what the specific symptoms are, but their overall symptom, and you can use a validated symptom score questionnaire, such as the COPD assessment test, which I'll discuss later. The exacerbation frequency, again, their lung function, oxygenation, chest imaging, and how much of inhalers they're using in preventers and reliever medication. So once you've determined the severity, it's useful to help guide initial therapy. And I don't want you to memorize this slide. It's just to really illustrate that there is a process in international guidelines, both from the ERS and other international guidelines, to help differentiate between patients with high initial severity of disease versus low initial severity. Helps you to sort of make a decision on their inhaler use. Impact is sort of more helping with their specific symptoms. So I should go to this particular slide. So this is the COPD assessment test, and this can be useful for assessing both severity and impact. So severity I take is sort of more the total score. Once you've sort of summed everything up, what is their total symptom burden? But impact is looking at these initial or each component individually. So there's 8 questions here, each one asking a specific symptom, and you grade that out of from 0 to 5. So at a glance, you can very easily see what the patient's main concerns are, and you can address that very specifically. For example, you ask about their cough, phlegm, tightness, shortness of breath. They're confident to do daily activities and sleep. So, there's a management plan for each of these. And this just helps you to sort of tease out what their main problem is. For those that like sort of to go by more local guidelines, the COPD-X is the local Australian guidelines, and you can use this guideline once you've assessed the impact of the patient tailor it to their specific needs. That point about, has the patient started smoking again? That's very important because preventive therapy really remains paramount. We know smoking is associated with accelerated lung function decline. That if you stop smoking, that your trajectory of lung function decline doesn't return to normal, but sort of the rate of decline does slow down back to normal age-related decline. So the sooner you stop smoking and continue to remain abstinent, that's very important. So what in the case of you've gone through assessing their stability, assessing the impact of COPD, and they continue. So for example, you've gone through that framework to increase their inhalers, but they're still having symptoms. And what now? Well, it could be that, yes, the underlying disease has progressed, and that may be the case if the patient has taken up smoking again, if their treatment inhaler is inadequate, or they've had exacerbations, and sometimes that can be infective or non-infective. In terms of complications, COPD is associated with certain lung complications such as interstitial lung disease. And you can see one of my patients with a CT scan at the bottom who's developed a interstitial lung disease, we think likely secondary to his COPD ongoing smoking. Lung malignancy, of course, as that PET scan at the top illustrates, that is a very real risk we need to be on the lookout for. If we are also very mindful of a judicious inhaled corticosteroid use because of the increased signal or risk of pneumonia, so making sure that's only used in appropriate patients in COPD. And if not, yes, they can certainly be at high risk of a complication of pneumonia. On the point of checking whether they've adequately treated, well, there's a multitude of inhalers, and that's already been sort of well illustrated by Barton. And this, I guess, picture just serves to illustrate even further that there's a lot of combinations out there. And sometimes just seeing them on the, writing them out from MIMS or seeing them on the computer screen, clicking it, it's sometimes easy to not have at the forefront of your mind the actual device and how that impacts the patient. Not only the dexterity factors, for example, some patients might find it hard to use a Respimat device where you have to use strength to twist if they've got severe arthritis, for example. But another thing that you may or may not be aware of is the importance of inspiratory flow to a patient actually getting the right amount of dose delivered. So each of these inhalers will actually have an internal resistance, and a patient has to generate adequate inspiratory flow to overcome that internal resistance before they get the adequate, optimal dose from the inhaler. And each manufacturer will publish an optimal flow rate for the inhaler and also a minimum flow rate. And some of this has been published and studied as well in COPD patients. So just where I've highlighted is a population of patients with severe COPD, and they've used a device which simulates the internal resistance of different inhalers, for example, the Accuhaler, Turbuhaler, and Autohaler, as well as a metered dose inhaler, and to determine whether these COPD or how much inspiratory flow these severe COPD patients generate from each inhaler. As you can see, the Turbuhaler, on average, the COPD patients could only generate 18 liters per minute, whereas the published minimum required flow rate is actually 60. So that's actually nowhere high enough to meet the requirements to get the full dose in. Whereas a metered dose inhaler, the minimum is 25, and severe COPD in this cohort could generate 80 liters per minute, so no troubles there. So if a patient says to you, well, doc, I don't think this inhaler is working, they could be right. And there's a couple of ways to test that. If you've got a demonstration advice, you could just ask them to demonstrate the technique in front of you, and maybe you'd be very easily be able to see that they're sucking away at it and it's not really doing anything. If you happen to have the lung function report in front of you, then the flow volume curve will provide that information. So this is the inspiratory loop of the flow volume curve, and if this is very flat or lower, then that can provide a clue. You don't have to know the exact numbers, but it could also provide a clue. In general, the higher degree of expiratory airflow obstruction, the higher degree of inspiratory airflow obstruction as well. There is a commercial device you can use, the InCheck device, which exactly as that study used, sort of simulates the internal resistance, and it can give you an idea what the inspiratory flow is, but not commonly used by all means, but it's available. Other causes of difficult to treat COPD, it may not be their COPD at all, but one of a few comorbidities often seen together with COPD. Breathing pattern disorder is very common, not just in COPD. It can happen as a primary disorder or in combination with other respiratory conditions. It's quite distinct from anxiety. It's not anxiety, but hyperventilation forms part of it. It's sort of a maladaptive response to dyspnea. So the feeling of shortness of breath often triggers a hyperventilatory response, and that can be addressed through breathing retraining. Vocal cord dysfunction is more commonly seen in asthma or associated with asthma, but I've had patients with this condition also on COPD. It's a involuntary paradoxical closing of your vocal cords with inspiration, and that can give the sensation of choking or throat tightness, as distinct to sort of feeling more tightness lower down in the airways, but it can be hard to tell apart. Most people think of obstructive sleep apnea as a condition in itself, but it is associated with sleep apnea. Not all COPD patients are cachectic either. Some are obese, and that condition can coexist. And COPD being a systemic disease, there is higher risk of cardiovascular problems as well. Only once you've excluded all of that or given it some thought, then and really stuck, would you consider whether we need to reassess the diagnosis, reassess the history to see if there's an occupational component, whether there's reversibility on the lung function that might indicate asthma, or whether they might have risk factors for rare diseases. Connective tissue disease, for example, can lead to a condition called bronchiolitis obliterans, which gives severe airflow obstructions and reduced gas transfer as well. On that point of asthma and COPD, sometimes they can overlap. So it may be that a patient has asthma since childhood and then been exposed to risk factors and developed fixed airflow obstruction in a very sort of COPD sort of pattern on their lung function. There are some clues. Usually asthma, if it exists, will have more of a variable pattern in both the pattern of symptoms and also the lung function as well. Of course, if there's significant bronchodilator response, that is a big clue. But that's not always seen. All right, so if you are dealing with a situation where there's progressive COPD and there's not any other comorbidities, then there are still some therapies which can be appropriate for certain populations of people with advanced COPD. Things such as non-invasive ventilation with BiPAP, which is essentially a home use ventilator, much like a CPAP machine, and that's appropriate for patients who've had a lot of exacerbations, come into hospital a lot of times with respiratory failure, high CO2 levels. That can really help prevent their exacerbations if they have a BiPAP machine to offload some of that CO2 in their sleep. Lung volume reduction is appropriate for very selected patients who have a lot of hyperinflation in their lungs, a lot of trapped gas because they can't empty their whole lungs with each breath, and they end up sort of blowing up like a balloon. Traditionally, it was done surgically, but now they have these one-way valves available where they allow the trapped gas to come out, but not back into the affected regions, and there's better ventilation perfusion matching as a result of that. Lung transplant. This is, again, an even more selected population of patients where their prognosis is very poor, generally less than 24 months on maximal therapy and without absolute contraindications, of which there are several, including cancer, major cardiovascular disease or other major organ dysfunction, poorly controlled for psychiatric disease or substance abuse. Ongoing smoking is a flat out no for at least 6 months if they can remain abstinent. Okay. And finally, oxygen therapy. So this is an option for patients that do have either resting hypoxemia, so the oxygen levels at rest, or if they desaturate on exercise. It does help them to live longer if they start on oxygen, but that effect only comes in after 2 years based on very old studies, but they say that the mortality benefit is more apparent after 2 years. And the other important thing is that it must be used continuously throughout the day, having a break only over at night. But it can really improve things like exercise capacity, help them feel a better happier and improved mental state, as well as some of their hemodynamics. So it helps the numbers look better. But I think the most important thing is exercise capacity, helping them to do more and get around more easier. All right. That's all I had. I'm very happy to answer any questions.